Dr. Magda Raban is Senior Research Fellow in the Centre for Health Systems and Safety Research, or now it's called CHASER, so I will use that from now on. She is the lead for the Medication Safety and Electronic Decision Support research stream within the centre, and her research focuses on the use of information technology to improve medication safety, the quality use of medicines and patient outcomes across a range of care settings. She has practiced as a pharmacist in Australia and in the UK, and prior to her working in research. So, if it's hand over to Magda.
Thank you, George. So as you've heard this morning, this program of research not only looked at prescribing errors, but also at medication administration errors, and I'll present some of the preliminary results from that analysis now. And that's quite a unique component of the research, because generally medication administration errors are looked at less frequently than prescribing errors. So this is a systematic review that we did a couple of years ago now, looking at the prevalence of medication errors among paediatric inpatients. And what I've done is just pull out the number of studies that we identified looking at prescribing errors versus administration errors. So you can see there that we had 58 studies that looked at prescribing errors and only 25 that looked at administration errors. Furthermore, only 3 of these studies looked at administration errors in a hospital with an eMM. So there's a clear gap there in the literature. And this not only applies to in the paediatric setting, but also more broadly for medication administration errors. Well, what do we know about medication administration errors in the Australian context and the impact of eMM? So these are a snapshot of results from a study that we did in the two Australian adult hospitals, and we had an overall administration error rate of 30% of administrations with 1 or more error. The most frequent error types in this setting were wrong IV rate, wrong timing, and wrong dose. If we look at the proportion of administrations with an error by route, IV administrations stood out as having a much higher proportion than overall, so 70% of IV administrations had more than 1 error in the adult setting. And in this study, we reported a decline in administration errors after the introduction of eMM, but that was a relatively small decline, and it was largely due to a reduction in wrong timing errors. So to measure administration errors in the paediatric setting, we use the same methods as in the adult setting, and this involved direct observations of nurses preparing and administering medications. And this is important because you can't identify all administration errors purely from chart review. You need to know what is going on in the whole process. So we had a team of nurse observers who conducted these observations on the 9 study wards, and they recorded all the details of the medications being administered on a handheld device. Importantly, the study wards didn't include ICUs, the ED or oncology wards. Because there was a team of nurse observers, we conducted inter-rater reliability testing to make sure that data was being captured consistently across all the observers. And the data that I'm presenting in this presentation is the data from that stepped wedge period, which Joanna talked about in her presentation earlier. And that's important because we will also be looking at results from administration where we extended that data collection to periods outside of that stepped wedge period in order to answer some other important questions about medication safety practices. So this is a snapshot of the tool that we use to, the observers use to record all the medication administration details. It's called the Precise Observation System for the Safe Use of Medicines, or POSSUM for short. And you can see there that it allows capturing details of the nurse that's administering the medication, some patient details, as well as the medication details. Additionally, there's a range of procedures that can be recorded in this tool as well, for example, when the medication was signed for, and some of those procedures will be looked at in a little bit more detail in presentations later today. Once all that data is collected, then the observed data are reviewed against the medication charts to identify errors. And this is a screenshot of the Possum web app that the nurse reviewer uses when reviewing all the observations against medication charts. And you can see it allows a comparison of step by step of the process that was used in the administration. The broad definition of an error in this study was that the observed administration was not according to the prescribed order or not according to accepted clinical guidelines for the preparation of medications. And once all the errors had been identified in each administration, the potential harm from those errors was rated on that 5-point scale that Joanna presented earlier today. We had 17 clinical error categories, everything from wrong patient down to wrong solvent or wrong diluent volume, for example. And we allowed a 10% dose difference for dose errors and a 1-hour window either side for wrong timing errors. We also had 4 legal or procedural error categories, so that the order wasn't signed for, so no signature or no time of administration being recorded. The observed administration was different to what was recorded, so this is if what was signed for was not actually what was observed in terms of what was administered to the patient, and administrations from incorrect, illegal, or incomplete prescriptions. So during the step-to-edge period, we observed 284 nurses administering over 4,500 medications being administered to 1,380 patients. And so what did the errors look like? So overall, 36% of administrations had one or more clinical error. And if you think back to the results from the adult study, that is very similar. In that study, that proportion was 30%. And again, if we look at the proportion of administrations with an error by IV route, you can see the same pattern that we saw in the adult setting, in that the IVs had a higher proportion of administrations with one or more error. So 63% for IV infusions and 76% for IV injections or boluses. If we pull out the errors, administrations with an error of serious potential harm, those proportions do drop substantially. So you can see it's 6.1% of administrations with an error for the oral route. The IV routes remain consistently higher, though, than the other routes. And you can see for IV injections, that proportion is still around that 60% mark. So what were some of the common errors that we saw with the IVs in particular? Most often these related to fast rate of injection. So I've pulled out an example here of 70 administrations that were observed of benzyl penicillin, 31 of which were given as a bolus injection. So for 7 of those injections, 7 were actually a wrong route because of the age of the child or the dose being administered. And of those injections, 4 were administered at the correct rate, which is a minimum of 5 minutes. And the fastest administration time was 31 seconds. Okay, the next thing we wanted to know was what was the impact of the eMM on these errors. And after looking at adjusting for the study design and patient age and clustering, we found that overall there was no difference in administrations with one or more clinical errors after the implementation of the eMM. And similarly for administrations with an error of serious potential harm, there was no difference. And given what the results that I've talked through prior to this, it's perhaps not surprising that the eMM won't impact things like wrong IV injection rates. But we did also want to know if there was a change in any of the particular error types after the implementation of eMM. So we looked at this across all the error type categories, and most of the error categories remained pretty similar in the paper and eMM periods. The one error category that did increase after eMM was the wrong route error category, and we broke this down further to look at the routes that had that were more, to compare that rate across the different routes. And that's the graph that you can see on the right-hand side of the slide here. So the orange bars represent the proportion of administrations with an error during the eMM period versus the proportion in the paper period, which are the purple bars. And again, you can see that the IV routes both had an increase in wrong route errors after the implementation of the eMM. So we did go and look at these further to try and look at why this was happening. And if you think back to our definition that the administration had to match what was prescribed, in the eMM we had doctors now prescribing the type of IV that needed to be administered. So previously on paper, the prescription would have just said IV, and the nurse would have picked which IV route to use. In the eMM, the doctors do have to select whether that's an IV injection or an infusion, etc. And so a lot of the time, the nurses were selecting what was in line with practice on the ward or appropriate for that patient. And when we look at whether those administrations were according to guidelines, the majority of them were actually according to guidelines. So I guess then the immediate question is, well, does this impact? If we don't consider these as errors, what happens to the impact of the eMM? And we did have a look at that, and there is no impact of the eMM, even if these errors are taken out. But I guess this point just does raise questions about some of the shifting workflows with the introduction of a new system, and perhaps how we, whether that impacts how we consider the design of the system. We also looked at the procedural legal errors in the paper and the eMM, and you can see that overall these errors were very low. So only 1% of administrations didn't have a signature. And the numbers in green are the ones that did improve. So the time of administration being recorded improved with the eMM, as did the administration of medications with an incorrect or illegal prescription, as we might expect based on the reduction in prescribing errors overall, as reported by Joanna earlier. The one error category that did increase was that the observed administration differed from the record. Again, overall, this was fairly low. So in the eMM period, 10% of administrations had a discrepancy between what was observed being administered and the record. And this related to the example that I provided earlier, in that and the level of automation with the system as well. So when a nurse is signing off on an order, it is automatically signed off as what was prescribed as being administered, unless that is manually updated in the system at the time of sign-off. So I suppose that just illustrates that sometimes there is an efficiency trade-off that we have when we automate certain procedures within the eMM that can then lead to a reduction in the accuracy of the information being recorded. So in conclusion, in the paediatric setting, we found 1 in 3 administrations had 1 or more clinical errors, which was a very similar rate to what we saw in the adult hospitals. More IV administrations have clinical errors compared to other routes of administration, again in line with what we saw in the adult setting. And more thought is needed on how we optimise eMM for medication administration, and perhaps some discussions around other medication safety practices or interventions that may target these errors. Thank you.
We probably have time for one question. If anyone has a burning question they want to ask Magda at this stage.
Hi, Vicky Smith. I'm from Sydney Children's Hospital ICU. I suppose I was just interested to see that you excluded the critical care areas and oncology, and those being sort of the highest risk areas. So I just want to know, is there plans for maybe future research into these areas to give even more data? Because I think that would be really interesting to see. So.
I agree, that would be an interesting area. I mean, we were directed by the hospital and the network. What wards would be included in the research. But yes, I mean, at the moment I can't speak to any settings, but we are definitely thinking forward and looking ahead.
Thank you. Thank you, Magda.